We get a lot of questions about platelet-rich plasma or PRP therapy. This is a form of regenerative medicine. It's kind of a hot topic in orthopedics these days. Some people pay a significant amount of money for stem cell therapy. There's some amniotic tissue therapies out there. We in our office provide the option for PRP therapy or platelet-rich plasma. There are a lot of good articles that have been published recently on PRP that show that PRP has a lot of potential to heal certain kinds of tears. PRP, in my experience, and what some of the data is showing, is that it's worthwhile for partial rotator cuff tears, partial tears in the elbow, otherwise known as tennis elbow, also for partial Achilles tendon tears, and I've used it for some meniscus tears. And where PRP comes into play is for patients that may or may not need surgery, but they have some sort of a tear and they're looking for options other than surgery. And so we will talk to them about the potential of PRP for them. And essentially the way PRP works is we take the patient's blood, just like a lab draw. If you go and get your blood drawn for a lab test, we do the same procedure in the office. We draw some venous blood, and then we put it in a centrifuge machine, which is basically just spins really fast. We do that for a certain amount of time, usually 5 minutes or so. And this machine or the centrifuge action separates the red blood cells, which we don't want to inject, from the platelets, which we do want to inject. And so we harvest the platelets. And so we put red blood in the machine, and what we get out is yellow platelets separated from the red blood cells. And we take the yellow platelets and we correlate where the patient hurts with the MRI and the partial tear and or the ultrasound showing a partial tear. And we sterilize the area, and we do this just in the office. Sometimes we use ultrasound to localize the needle where we're going to place the PRP, and we place the PRP at the location of the tear. Initially, patients get an inflammatory reaction and can feel increased pain and inflammation for a few days to a week. We ask them not to take anti-inflammatories because we want that inflammation to happen. That's part of the healing process. And then over the next few weeks, we usually find that the patient reports decreased pain in the area. It doesn't work all the time. There's nothing that works all the time. We usually tell patients when it's worth trying for them. And we usually quote about a 50% success rate, although I think it's higher than that. I just don't want to overpromise patients. The downside of PRP is that the insurance doesn't cover it. So it is out-of-pocket expense. The upside of PRP is it's not surgery. It's done in the office. And in about 6 weeks, we should know whether it worked, the procedure worked or not. So I have over time, I was reluctant early on to get too much into the PRP because the data wasn't there. But as the data and the medical literature has supported it, we are now having this discussion with many of our patients just on a daily basis. And we're finding that it's helping out a lot of our patients.